Thank you. I apologize. I think nearly everybody's asleep. Hi, guys. Can you put your hands up first? Hands up all the way. Everybody. Good. And move, wiggle. Okay, great. Okay, let's start. Cervical spine injuries, again, it's boring. You know it all. Patients at risk. Types of injuries. I'm not going to go into this. Just go into educational objectives. This slide was I taken from Mammoth, and that's why I'm so organized in this particular presentation. So this is what you're going to look at. So first look at locked facets. So, when we have severe flexion injuries and we are coming down like that, automatically you get jumped facets. So you can have jumped facets with reversal of normal shingle shape relationship that we have. Facets that have significant ligamentous disruption, you could have perch facet in which they are just perched, just at one angle and not gone all the way out. On the other hand, if there's flexion and rotation, you get unilateral facet. And if it's hyperflexion, then you get bilateral facet dislocation, subluxation. So laterally, you see this bow tie sign. So, that bow tie sign, visualization of left and right facet at the level of injury instead of the normal superimposed position subluxation. So disruption of posterior ligamentous complex may produce widening of the interspace between spinous processes, and that's when bow tie sign comes into play as well. The other thing we can see clearly is that naked facet sign, and this is the articular surface of the facet will be seen not articulating, but lying separately, free, naked, and that's why it's called naked sign. And on MRI as well, you can see it as well. Management of facet dislocation, if it's mild unilateral facet dislocation, conservative treatment could be an option. I generally don't offer that, but that a patient is not fit for surgery, there's other reasons that you can't do it, then yes, conservatively it could be treated with orthosis. With bilateral, obviously, are unstable and needs to be surgically stabilized. Closed reduction, awake patient, reduction performed with monitoring. So if patient is awake, then it's easier. Then it's much easier to reduce without causing any problems. And it's not essential to obtain pre-reduction MRI because if you're reducing it and patient is awake, you know that the patient you will not give problem if patient is awake. It's successful in about 90% actually, I'd say, of facet dislocation. But with maturity, I think people get better and better. Incidence of extruded disc is, although up to 42% reported, but clinically significant was 1 in 400 cases. So I think really negligible. So you can actually, if you haven't done an MRI, you can still proceed and you will not run into trouble. But it's controversial because in US, majority of our friends would do MRI before going in. With us, in our unit, we have the opportunity of having 2 MRI, one freely available to us all the time, so we do it beforehand. What's the disadvantage? You transport to MRI, inability to monitor BP or neurological status, delay in reduction, delay in relieving the cord compression. Traction, not going to tell you what to do with the traction rates exactly. With unilateral locked facets, one may gently manipulate manual torsion towards the side of the locked facets. With bilateral locked facets, one may have to add gentle manual posterior tension. I'll show you there. Once the facets are pushed or distracted, gradual reduction of the weights could result in reduction. So open reduction of locked facet, you could have posterior approach or anterior approach. Posterior, dangerous in the presence of disc herniation, that's what we say, but it's very rare. Requires 3 vertebral fixation for one motion necessary to excise the facets, also require 3 ventral fixations. Whereas anterior, single segment orthodesis, lower infection rate, higher etiological union, better lordotic alignment, voice changes and dysphasia could be there, especially for people whose career depends on that. Reduction, simple distraction could do that. Interbody spreader, I've taken this from Ed Benzel's book. And so cloud interbody inserted at 30 to 40 degrees into this space. You don't want to be making it too short, otherwise you'll break the vertebra. Distraction applied while rotating the instruments superiorly. So you bring it up and rotate at the same time. So if it's unilateral, you'll get disengaged on that side. So whichever side is dislocated, that's the side you put the distractor. Bilateral facets, spreader placed in the mid of the vertebral body with unilateral on each sides. and you need to reduce that risk of vertebral body fracture by putting in a too short. Then you can have poles that you can put in, and convergent placement of these posts can be put in, and then you distract, and automatically it opens up the thing. Once it opens, you can push with your finger or rotate on one side or the other. And this is quite simple to do once you're used to it, and it's the easiest way of reduction. The relaxation of forces, re-engagement of facets in normal position will happen once you disengage. If it's unilateral, the posts are placed laterally on one side instead of in the center. Cervical spine injury classification, there are various, but example are types of injuries. So for example, if you have got flexion, extension, and neutral position. So flexion, if it's unilateral or bilateral facet dislocation. With compression, with flexion, it automatically becomes anterior vertebral body fracture with kyphosis, and then going on down to the teardrop. With distraction, you could have torn posterior ligaments or dislocated or locked facets. Extension, the same thing. Sorry, we're running short of time, so I don't have time to go into that, but I can show the picture. So compression flexion injuries, this is the severity as it goes down and on to the retrolithiasis more than 3 millimeters. So with the distraction flexion injury, and so flexion sprain, you can see that the whole thing opens up like that, and then complete spondylosis could be the end result. I'm sorry, just running short of time. Compressive extensive injury, extension injury, you get unilateral vertebral arch fracture to start with the arch fracture, and you can go on to complete spondylolisthesis, one on top of the other. Classification, we already know this, subaxial cervical spine injury, not going to go into the detail of that. AO spine, already you guys know it all, so not going to go into that. But clearly, they have both these classification systems have shown to be very effective for making decision making as well as deciding how you should go about a plan. Vertical compression fractures, burst fractures are the most common fractures, and possibility of retropulsion into the spinal canal with neurology could be a problem there. Compression flexion injuries, classic diving injuries, the prototype. Posterior element fractures occur in up to 50% of the compression flexion injuries. Burst fractures, important feature is displacement of the inferior margin of the fractured vertebral body posteriorly into the spinal canal. So it's usually unstable, and patients are often quadriplegic. If they're intact, they may have anterior cord syndrome. Mild cervical compression fractures without neurology could be treated in rigid orthosis. Stability is assessed with flexion extension at 6 weeks, and then can decide are we going to continue or not. If the disc and ligaments are intact, then the option is to employ a halo. I don't give halos. There's a lot of problems that we see in our patients. When the injury is primarily posterior due to disruption of posterior ligaments and facet, there is no anterior compromise of the canal, then posterior could be done. This is the algorithm that we use. So unstable reduced fractures, anterior neural compression, no. Then we go posterior disruption, no. Then posterior approach. Otherwise, they're going to have the anterior approach. Algorithm for management of displaced unstable fractures. Not going to go into that. Too short of time. Take-home message. Majority of acute, less than 3 days locked facets, anterior surgical techniques are sufficient to manage successfully. In chronic locked facets, more than 2 weeks, lower cervical locked facets with no insignificant disc prolapse, and in conditions where the anterior approach is not feasible, a posterior approach is indicated. All locked facets should be reduced in an emergency, and surgery should be performed as soon as possible. So if you're going to do awake, it would be very good that if you do that whenever a patient comes in. If you can do early surgery, that would be the way forward. Subaxial injury classification system is safe and effective in guiding the treatment of subaxial cervical spine injury. There is good agreement in the SLIC score and the treatment chosen. For injuries with an SLIC score of less than 3, non-surgical treatment with rigid collar for 6 to 12 weeks is recommended. For injuries with SLIC score of more than 4, early surgery. Surgery is indicated for presence of progressive neurology. Anterior surgery is recommended for significant anterior column fractures. Guys, you are most welcome to WFNS educational course that we have in January, and hope to see you all there. Thank you.